Hello and Assalamu alaikum and welcome to this webinar, which is collaborated with Kidney Research UK and BIMA, British Islamic Medical Association. If I could just ask if everybody could just put um, uh, themselves on mute, just so that we don't disturb those that are speaking. Is that okay? I'll just put this person on. Right, thank you very much. So, like I said, thank you very much for joining us today. My name is Bishra Riaz and I work with Kidney Research UK. So I will start off just with a short introduction about Kidney Research UK, and then I'll hand over to Dr. Shafi Malik and Dr. Salman Wokar. So if you just bear with me, I will just share my screen. Okay. Okay. Is that okay? Can everyone see my screen yet? Okay. So, like I said, I'm Bishra Riaz. I am policy lead and I am based in Scotland. And I've been with the charity for the past 7 years, currently working on a project with the Peer Educator project, which is based in Scotland, working predominantly with the South Asian communities, with the Sikh, Hindu, Muslim communities on the organ donation project. I also work in policy, which works with governmental and parliamentary officials, making a change with around chronic kidney disease. So just a little bit of information around who are Kidney Research UK and what does the charity do. So we are the leading charity committed to developing treatments, patient information and raising vital public awareness to help save lives. The charity has now been running for the past 60 years and the research has made an impact. There's approximately estimated 60,000 people with kidney failure who are alive today because of the advances in research that we have directly contributed to. And the research that we funded is making significant progress in keeping retrieved kidneys viable for longer, which would mean less kidneys go to waste and more are viable for transplant. And there's a lot more further information on Kidney Research UK website, on our Twitter, which is now X, and Kidney, and on Facebook and LinkedIn. So just a bit of information around what we are involved in. So like I said, our charity focuses on research and we are involved with a lot of research with our PhD and fellow students. Just some of the, I'm just taking some snapshots from our website as well of what we're involved in. And currently we're doing a lot of work around diabetes, CVD, and the correlation between CKD and other multimorbidities as well. One of the main research which I'd like to just highlight today is the research that Kidney Research had contributed to with the University of Cambridge. And what this did was it changed the blood type of kidney. So people that were blood type A could not be transplanted into those that are of blood type B. So what they did was they could change it to blood type O, which then could be transplanted. So for people from the ethnic minority communities, this was a great breakthrough for those that had been waiting for a long time. As we know, within these communities, a large number of people are waiting for a transplant, will wait longer for a transplant because of the lack of number of people that sign up onto the organ donor register. So like I said, on our website, we have lots of information around this, so please do have a look around. So just discussing what we're doing around diabetes and CVD as well. So currently we are, just recently in February, we are funding a researcher to look at the diabetic eye disease treatment, and does this affect kidney function? So the steroid injection that a lot of the diabetic patients have to endure, what we're researching is how does this affect kidney function and what is the correlation between that as well. A report that was written just on Friday there that was highlighted in the newspapers that came out from the British Heart Foundation showed that kidney patients are up to 8 times more likely to suffer a heart attack, which is quite an alarming result. And this again is something that we're looking into as well. And we do a lot of work with British Heart Foundation as well. Most recently, we have our core morbidities, multimorbidities project lead, who is now working very closely with a lot of charities around diabetes and kidney research, and how can we work together to raise awareness and the work that needs to be done as well. So, like I said, just a couple of weeks ago in February, they attended a workshop which was hosted by Kidney Research UK and Diabetes UK, JDRF UK, attended this event. It was attended by academics, clinicians, patients that talked about lived experience, those that have got multimorbidities and how it impacts them as well. So there was a great outcome, great discussion, and now this is now going to lead forward to writing an article and drafting a report, which will then now be produced at the Diabetes UK conference, which is being held in April. So on the back of that as well, we have taken part and drafted 4 major reports with the charity, looking at 4 different aspects. Mental health is a major issue which affects kidney patients, and it's normally kind of, as you would say, not given the highlight that is required. So what we did was last year at World Kidney Day, we ran a survey which wanted to highlight and speak to patients that suffered comorbidities, multimorbidities, and also those patients that had kidney disease as well, and how it impacted them. It was quite alarming because we found that 67% of those that had kidney disease suffered severe mental health problems, and 27% also would consider self-harming or committing suicide because of their condition. So on the back of that, the mental health report, which is now available for all to read, was drafted, and it highlights the need and necessity to have a kidney renal psychologist in every renal unit in the UK. We are also having looked at, and we still are looking at the health emergency in the UK when we're looking at the impact economically on the health economics report. We found that kidney disease is a huge impact, and if there's no prevention or there's no interventions taking place within the next 10 years, there will be a huge deficit in the government in terms of the pressure that kidney disease will impact. So more needs to be done around that as well. In Scotland, we produced a policy report, which was Changing the Future for Chronic Kidney Disease in Scotland. And what we looked at was the recommendations and the need for early diagnosis, prevention, and looking at more work that needs to be done around pathways for patients. So we're looking at this in more in detail, and now we have now drafted an action plan that we're taking now forward to government. And this is also running now in England as well, where we're now just drafted the chronic kidney disease and prevention policy report, and that's with the support of an MP, which has been fantastic and it's been taken on board. So when we look at it as well, we have now got a petition running in Scotland as well and what this is doing is it's highlighting the need for chronic kidney disease to be made a clinical priority. We're using Scotland, and we say Scotland obviously being based in Scotland, but this is UK wide, so anybody can sign this petition. And what this is doing is basically highlighting the need of what chronic kidney disease, the importance that is required, as normally is not given importance that is needed. So some more collaborative work, which is more community-based work. So just to highlight a couple of things that are running just now. So we are in collaboration with Kidney Wales just now, and we have been funded by NHS Wales and Diabetes UK Cymru. We're running a new project which is looking at patients that are diabetic, and those to making sure that they're getting their testing done to make sure of how prevalent they are for kidney disease. This is a project which is run by our Health Inequalities Manager, Nirja Jain, and it's by using peer educator volunteers as volunteers from the community of the South Asian communities and the lower socioeconomic communities within Cardiff and Newport. And we're looking at ways to uptake the testing, and it's a great initiative to see, and it's alarming results coming out there. And then Nurja Jane will be writing and drafting a report on the back of that. We're also doing a lot of organ donation work around kidney wheels as well. We're working with the South Asian communities, with the Sikh, Hindu, and Muslim communities, and we also have hosted many webinars and interfaith work as well. So this is just a whistle-stop tour of the kind of work that we're involved in, and we're trying to reach out and do more within the health inequalities, and to raise awareness around the multimorbidities that impact the South Asian communities as a whole and the wider communities in the UK. So thanks very much for giving me this time, and I will now pass over to Dr. Salman.
Thank you very much. Assalamu alaikum, good evening, and thank you for inviting myself and Dr. Shafi to deliver this presentation. I'm just going to pull up my slides here. Hopefully you guys can see that. If you could just nod or give some indication if you can. Thank you. So thank you to Kidney Research UK as well for collaborating on this really important topic, which I hope we will, throughout the course of this evening, get a bit of a better appreciation as to why it matters. Just to introduce myself, my name is Salman Waqar. I'm a GP and academic down south in Buckinghamshire in England, and I'm also the president of the British Islamic Medical Association. And alongside Dr. Shafi and many others, we have taken a significant interest in the evidence base and the clinical management of patients who fast in Ramadan. And so what we're going to present to you is the framework that we have put together, which hopefully enables healthcare professionals to do in a shared decision making process with their patients who intend to fast Ramadan, and also those who may not want to undertake that journey, to have them understand what alternative options they may have. So this usually we present in varying formats, so hopefully this won't be too condensed, and there will be an opportunity for questions at the end. But I just wanted to start by first highlighting the fact that fasting as a concept isn't something that is unique to the Muslim faith. And in fact, actually, it's something that's become quite topical at the moment, with people doing things like intermittent fasting or the 5-2 diet. And it is natural that people would want to try and understand actually how does this relate to the health. And in those non-religious forms of fasting, there is some benefit that has been derived from it, in terms of it's not only what we eat, it's also when we eat, in terms of time-restricted eating. And this is, of course, pertaining to people who don't have existing conditions, but there is a lot of interest in terms of what does this look like for people who have got established disease, particularly metabolic disease, which can lead to kidney disease or be involved with kidney disease as well. Fasting as a concept, this is a bit of a technical slide for those of you who don't perhaps follow the science, but fasting essentially is what happens when you're fasting is that you no longer have sugar, no longer have glucose entering into your blood, into your bloodstream, as your body breaks down the food. And as a result of that, essentially your body switches from trying to use glucose or sugar as the main form of fuel into using fatty stores that we have. And this process of the metabolic switch is essentially what's happening during fasting. And the longer you fast and the more consecutively you fast, the more the switch takes place. And this is essentially where the health benefits of whether it's Ramadan fasting or other forms of fasting, these are derived from. And as I said, there are significant benefits that may be derived from this. Some of these are mentioned at the top of the slide here, going from reduced inflammation markers, increased insulin sensitivity, and reduced blood pressure, and so on. But obviously, the way Muslims fast, we're not necessarily looking to do this for its health benefits, but it's important when we're talking about this Ramadan and health, that we understand that there's this process that's going on in the background. And as I said, it's not just the Muslims who fast. There are other faith communities who observe fasting. But what's unique about Muslims is that this is a fast which is perhaps stricter, in the sense that other faith traditions would allow medication to be taken. They may even allow the hydration to be had, for fluid to be drunk. And they may not necessarily be as long as the Islamic fast. But it's not in isolation. It's not an aberrant thing. Fasting as a concept is something that many cultures and traditions throughout the world and throughout history have undertaken. And indeed, those of us who are working or have other commitments will probably fast without realizing it. We may skip breakfast, having slept for 8+ hours, maybe not have a late lunch, sort of quite late in the afternoon. And had we had a dinner that was a bit early, we could have potentially gone several hours without eating or having drunk sufficiently. And so it's important to recognize that the body is able to adapt to these things. And we sometimes perhaps exceptionalize what Ramadan is, maybe due to some of the negative reporting and the negative cultural and political attention that is out there about Islam and the practice of Muslims. Excuse me. Let's Can you see my next slide? Oh, there we go. So what is Ramadan? For those of you who don't know, Ramadan is the name of a month. It's the 9th month of the Islamic calendar in which Muslims who are observant observe a complete cessation of eating and drinking for the period of a month, which, because it's a lunar month, it will vary from being around 29 or 30 days, depending on the length of the lunar cycle. And we do not eat and drink for daylight hours. So this is before the sun rises, up until the sun sets. So from dawn till sunset. And that means that you essentially start having two main meals: the pre-dawn meal, which in many cultures will be called different things, but the Arabic term for it is sahur, and the the sunset meal, which is called the iftar. And in the evenings, people will be socializing, either attending prayers. The night prayers are called tarawih. Or they will be having social activities such as coming together because of the social elements of Ramadan. But in addition to that, there's also a time for mindfulness and reflection. It is a commandment in the Quran, the Muslim holy book, that adults prepubescent individuals should observe this. And it's a religious obligation that's placed on people, but it's to gain God consciousness. That's the main sort of element of this. And there are many things that people will do in addition to abstaining from food and drink, such as giving more charity, such as exerting more self-discipline. And consistently, data have shown that Muslims across the world, regardless of how developed or where they are in the world, how secular the societies are, it is a phenomenon that most Muslims observe. Up to 93% of Muslims, according to the Pew Research poll, across the world will be observing Ramadan, even though they may not be observing other aspects, such as the Hajj, paying charity and praying, for instance. So all of the legal side and all the technical side of Ramadan aside, it's the one time of the year that for many people, it is the time that their family get together. It is the time where the social element kicks in, which may explain in some ways why so many people observe Ramadan and maybe forgo other Muslim rituals that are there. So it is of extreme importance to many Muslims, even if they don't practice other forms of their identity, to take part in this month. And the main way people look partaking in this month is to abstain from eating and drinking and to take part in that whole social phenomenon that I already described. Now, there are a lot of Muslims on the world, over 2 billion of us, that's a quarter of the planet. But we also have significant Muslim populations across the UK. And I've listed some of the cities here where the Muslim population in those cities, it matches the global population as well. So there's a significant cohort of patients here that we perhaps haven't thought about when it comes to the way that we deliver health and the way we design services. And it's important to recognize as Muslims, actually, our sociological experience isn't perhaps the same if we look at it from other angles of our existence, whether that's ethnicity, whether that's deprivation, whether that's your migration status. A lot of this all intersects and jumbles together, particularly in context of the Islamophobia that I mentioned that unfortunately exists in our society. And some of the cultural things that Muslims do that perhaps other South Asian communities may not do. For instance, halal food, for instance, the fast of Ramadan, for instance, abstaining from alcohol, which can lead to occultative stresses as well. So all of these mean that Muslim communities do find that they have suboptimal outcomes and indeed also suboptimal experiences as well when it comes to healthcare. And some of these I've listed here, won't go into it in detail, but essentially, and this isn't comprehensive by any means, but essentially there is poorer health for Muslims when it comes to however you look at it, whether it's exercise and prevention, all the way to, you know, how many medicines that they're taking or how they describe their health as well. And of course, religion for this community is an important part, whether that is a cultural manifestation or whether that is a theological manifestation. A lot of people will report that these beliefs form a big part of their decision-making process. And again, at the point I made around how long we fast, the length of the fast will be determined by the time of year we're in. So every lunar year is about 11 days shorter than a solar Gregorian year that you and I know about, and, you know, January, February, March, and so on. So that means over the course of 33 years, the months sort of slip back into the solar calendar. So right now, Ramadan will start around the 12th of March. Next year, 2025, it'll probably start around 11 days earlier, so probably around the beginning of March, and therefore that'll keep slipping back, which means that as we enter into this next decade, Ramadan will actually creep towards being around Christmas time, which means the days will be shorter. In 2019, it was actually in the summer months where we were at our hottest and longest days. And that, of course, is something that we need to bear in mind, especially when it comes to things around risk to do with hydration status as well, particularly important for people with kidney disease. And as I said, it's important that we don't exceptionalize some of these issues as well, particularly if people are in better health. We sleep for 8+ hours in a day. And depending on where you are in the year, in the world, excuse me, what time of the year, this graph here just shows in Sydney in 2014, people only had about just under 10 hours of sunlight during their winter as it was back then. Whereas we in London in 2014 were having 19 hours of sunlight. So you can see that vast difference that people can experience and that how vastly different the Ramadan fast and advice therefore will be for these individuals. So as I mentioned, it's really important as a phenomenon, as a ritual. This is very important to so many people all throughout the world. And many people will be fasting Ramadan despite having serious health conditions because they've done it before in previous years and they have felt that things haven't been too bad. What does this mean, though, in terms of medication? It means that people can't take anything by mouth or by nose. So any nasal or oral medications would be prohibited. And because people are altering their meal patterns, as I said, between two large meals in the morning, early in the morning, and at sunset, that can also affect the way that some medicines are taken and absorbed. And some routes are actually permissible, for example, injections. Many Muslim scholars will allow for that to take place. So there is some adaptation that can be made around many medicines. But it's important to note that the choice to fast or not fast, which we will talk about in depth in just a moment, it's not a binary choice. So we're not telling people you mustn't fast the whole of Ramadan or you can't fast the whole of Ramadan. There is a gradation that exists from being perpetually unable to fast because your health isn't, you have such poor health, in which case you may be wanting to speak to religious authority about paying charity in lieu of your fasting, to something around fasting in the winter months later in the year, not observing Ramadan in the month that it's taking place because of the heat, because of the length of the day, to trying to fast a few days of Ramadan or alternate days, depending on what you can tolerate. And again, we're talking here about capacitous adults here. We're not talking about prepubescent, so post-pubescent children, because their physiology is a bit different and it's a little bit more involved. So we're focusing mainly on adults here. And when it comes to health, as I mentioned, we are used to fasting as humans. We fast. The reason we call our first meal of the day the breakfast is because we break our fast. Physiologically, humans in good health are used to doing that process. The issue that comes around Ramadan performance, or issues around lethargy and things of that nature, are more actually related to sleep disturbance. So as I mentioned, in Ramadan, we will be staying up late due to social activities or due to spiritual activities. We will be waking up earlier to open our fast. And we will be doing this consecutively for 30 days, and that may not be many people's routine. All of this can add up to significant sleep disturbance due to the routine disruption. And it is that sleep disturbance that is actually the main driver, from the evidence at least, for any performance issues, any lethargy, any sort of issues around turning up on the day, as it were. So if you can acclimatize for that, by which I mean in this time leading into Ramadan, you can actually get used to that, encourage people to try fasting in ahead of Ramadan to understand how the body's going to adapt. You can actually get to a situation where this sleep disturbance or routine disruption isn't as deleterious for you, or you can look to see what adaptations you can do, for example, having a midday nap or and up towards the end of the day before you open your fast. And there's also opportunities here for public health intervention. So smoking, for example, would invalidate the fast. So people will be not smoking during the fasting hours. So here's an opportunity for us to actually really try and think about stopping people from smoking, or if you smoke yourself, to make this as an opportunity to stop smoking during Ramadan. And as I mentioned, your blood pressure will also come down to see what dietary changes you can continue keeping up to make sure your dietary modification persists beyond Ramadan as well. And I mentioned that alternatives to fasting do exist. If you are in perpetually poor health, such that you've been medically advised or you feel that you are unable to fast, you may speak to religious authority and not have to fast, because that is what is right for you. Fasting may exert a degree of hardship. It should not exert any degree of harm. That is essentially the principle here. And this is what we're trying to do with this presentation here, is to give health professionals and communities a degree of an understanding about where that balance lies and hopefully allowing them to have a more person-centered conversation with their clinicians. And again, if you are interested in terms of what happens during Ramadan and sleep, essentially just shift the time when you wake up a bit earlier, and you end up having a delayed sleep onset, and you end up having segmented sleep. So you don't necessarily get the same time in deep sleep, the rapid eye movement sleep that you get. And this is all essentially what is thought to lead to any performance issues that may come during Ramadan. So as clinicians, we know that, patients are very enthusiastic about this. If we don't match that enthusiasm, we know that we can sometimes push people away. So this is essentially for us a reminder for us that we routinely do these types of risk reduction type approaches with patients, and sharing risk with patients. And Ramadan should be no different. And I do find that actually, if people haven't engaged with health services before, if we actually use Ramadan as a means of trying to get them involved, we actually find that people who wouldn't normally come in as a GP, for example, to get their blood pressure or blood tests done, if we can use the Ramadan angle, they may actually be much more likely to come in. And likewise, I'm sure in a secondary care setting, in clinics and with specialists and so on, I'm sure the same would also be true. If patients are less likely to engage with therapy, if you go in with the Ramadan angle, they may be more interested in taking that up if they may not have traditionally engaged with you, perhaps due to mistrust or due to a belief that you don't understand who they are and what matters to them. So what we did during COVID is that we looked at the evidence, because there was a bit of uncertainty around what one should or shouldn't do, especially in the context of an infectious disease, what is safe and what isn't safe. And we created this guidance called the Ramadan Compendium. As I mentioned, Shafi and I, alongside over 100 clinicians and academics, were involved in that. And we used the framework that the International Diabetes Federation have been using to create a framework around risk stratifying patients into different categories to allow them to understand how they may go about it. Now, it's important to recognize that this work isn't authoritative, in the sense that it's more meant as a guidance, but it's a guidance that we have found that many people across the world have found to be very useful. And many of these sections that we are talking about have actually been published in credible peer-reviewed literature. So this is the resource that we're going to be talking about. If you have got a camera, you can take a snapshot of the QR code, or you can just type into Google the BIMA Ramadan Compendium, and that will come up. There's also another article there from the British Medical Journal, which is around fasting and how to have that evidence-based conversation with patients. And when you type in that BIMA resource, this is what you'll get. And these are the things that you will see, and Shafi will talk about these in just a moment. And essentially what we're doing here is making sure that as a clinician, you are making sure that you're having a conversation with the patient, which essentially does what we would normally do, but really hones in on the Ramadan experience, particularly the prior experience that the patient has had around fasting in Ramadan, and looking to see what changes they may have coming up. But the key thing we want people to take away from it is around risk stratification, which again, Shafi will talk about in just a moment, into very high or low and moderate risk. And these are evidence-based guidelines that and criteria that we're putting in. And as I said, Shafi will talk about just exactly what this involves. But essentially, if you're in a lower risk, we're saying that it's probably okay for you to fast with some advice. But if you're on a high, very high risk, this is where the conversation really needs to, this is where we hope we can add the most benefit around talking to patients in a way that shares that risk. And most importantly, actually telling them that they have got a high, very high risk, so that if they do need to speak to a religious scholar, a imam, or whoever, they can go to them with that knowledge to say that I spoke to my doctor, spoke to my clinician, And they said that I'm very high risk or high risk. And for many religious authorities, that terminology is very important because that's what they use in terms of their religious guidance that they give to patients, rather than often what comes up is this uncertainty from the doctors themselves, which patients then translate into further uncertainty for that religious authority, who then gives an equally uncertain response to the individual. And this also hopefully means that clinicians can feel confident in documenting for medical legal purposes their advice in a way that isn't making them feel unconfident or unsafe about patients. Just going back to that BMJ guidance, if you have a look at that, that goes through all of this in a lot more detail, and hopefully is a resource that you can lean back on if you're uncertain as to how you go about having that conversation. And just again to summarize, this is essentially what the guidance gives. It's important to recognize that there isn't, at least in the evidence basis, an idea of aggregating risk. So if someone has two green risk categories, say they've got diabetes and heart disease, it doesn't necessarily mean that that automatically becomes a yellow. And equally, if someone is green, they may still have issues with fasting because they may be extremely frail, or they may have other issues that are going on. So it's important to bear in mind that this is something that has to be taken alongside an individualized risk assessment and conversation with the patient. So I will stop there and I'll hand over to Shafi to give us a little bit more of a walkthrough with some cases.
Thank you. Thank you, Bush, for the invite, and Saman, thanks for setting the stage. So I'm Shafi Malik, transplant nephrologist in QE, and I, along with other colleagues at BIMA, have been involved in writing up some of the sections of the BIMA Ramadan compendium, namely the CKD and the solid organ transplant section. So you've already heard about the importance of Ramadan, the facts and figures, and also some of the alternatives and how important it is for patients, certainly in the high risk and the very high risk categories, to consult with a physician, either in primary care or secondary care, in order for them to fast safely if they should wish to do so. So my task, what I'm planning to do, is to talk a little bit about the background literature related to CK fasting and CKD, dialysis and peritoneal dialysis patients, some management recommendations, and then talk about renal transplant patients and a little bit about solid organ transplants as well. And then I've got a few case studies at the end. So majority of the literature actually comes is in CKD, hemodialysis and peritoneal dialysis comes from studies that have been done in the Middle East and North Africa. And only stable transplant patients and stable CKD patients were actually included in these studies. And there were a limited number of patients with CKD stage 5, pre-dialysis, especially pre-dialysis patients. There were a very limited number of patients that were included. There was patients on hemodialysis. However, there's only one study on PD so far. The outcome measures studies have been heterogeneous, and there's lack of long-term data. So this is just the background to all the literature in renal replacement therapy patients. So if you focus specifically on, let me just move to presenter view just so you can see the slides properly. Okay, there we go. So if you just talk specifically about CKD, there was a systematic review that was done, which identified 26 studies, of which 5 concerned CKD, non-dialysis and dialysis patients. Majority were actually done in the cold season, and only 3 were done in the hot months, i.e., fasting could have been better tolerated because it was mostly done in the cold season. So you just need to bear in mind when interpreting some of the evidence. Studies reported fasting was overall well tolerated in patients with CKD. However, there were some caveats, and we'll come to that in subsequent slides. There was a meta-analysis which came to a similar conclusion. However, majority of the patients were actually all CKD stage 3 or below, and there were few in CKD stage 4. but none in CKD stage 5 pre-dialysis. And as I said, there are only stable patients, so which leads to then a selection bias. Patients who either had unstable renal function, episodes of pulmonary edema, or poorly controlled diabetes were excluded from the studies. Patients generally were given low potassium diet advice and also asked to restrict their fluid intake. Antihypertensives and diuretics were continued, but modified to once daily preparations. And those with a tendency to developing hyperkalemia, either on an ACE inhibitor or an ARB, were switched to alternative medications. And although now we have newer potassium binders such as Pateromar or Lokelma, the trade name, but patients in these studies were actually given calcium resonium. This is an important study to mention because there was one study that actually looked at MACE as an outcome, so major cardiovascular events as an outcome in CKD stage 3 to 5 patients who intended to fast and eventually fasted. So it found that patients with a background history of cardiovascular disease had a higher risk of developing cardiovascular events, with the hypothesis being that dehydration causes hyperviscosity. So what it showed is if patients in stages 3 to 5, if they had a background history of cardiovascular disease, and if they fasted and when they monitored their serum creatinine, and an increase in serum creatinine after 1 week of fasting was associated with worse outcomes, and that was statistically significant. So we talked about CKD. We'll talk briefly about hemodialysis and then PD as well. So there were quite a few studies done on hemodialysis. However, I focused on just this one study only because of the numbers. So there were 635 patients, and this was actually a study, interestingly done in Palestine, and no statistical difference in measured parameters. However, fasting group were younger, they were working, and they were fasting on non-dialysis days, and no side effects SAEs were reported. And if you wanted to look at the left column, interestingly, the intradialytic weight gain or fluid overload between the dialysis sessions, in fact, remained quite stable compared to even the same patients prior to Ramadan. So it just means that, patients who are motivated to fast and they know that their health is likely to be at risk if they were to fast, but they were sticking to the medical advice given, i.e. they were probably watching out for their fluid intake, either measuring their blood pressure, measuring their weight. So then they were keeping a close check on their overall health while fasting, because they do know that it can tip them over the balance. And as I mentioned earlier, there was only one study on peritoneal dialysis. Again, unstable patients were excluded. And if patients were on CAPD, which is the continuous ambulatory peritoneal dialysis, so they underwent 3 exchanges with the light or medium bags. So we have 3 strengths of bags, as you probably know, the nephrologists would know in the audience. So light or medium bags. And it was done after dusk, so which is after iftar, as Salman mentioned. So after dusk, with a icodextrin daytime fill. So they would do their exchanges, 3 exchanges between sunset and sunrise, and then the last fill would be an icodextrin fill. And if patients were on the continuous form of APD or CCPD, they would undergo a rapid 6-hour cycle with similar icodextrin daytime fill. So the rapid 6-hour cycle would, again, after they break their fast, so after sunset, so they would do a 6-hour cycle with a daytime icodextrin fill. And in this study, the urine output or KTOV or creatinine clearance were no different. However, at least a quarter of the patient developed some form of complications. It was either PD peritonitis, although there were only 1 or 2 patients who developed PD peritonitis, but quite a lot of them developed fluid overload requiring either emergency dialysis or hospital admission. So this was a paper we published in 2021, looking at the effects of fasting in patients with CKD during Ramadan, and we offered practical guidance for healthcare professionals in case you want to look it up. And then what are the subsequent slides I'm going to show you would be from this study, where we devised a decision-making algorithm to help healthcare professionals. So it starts off, the flowchart starts off, does the patient intend to fast? And if they do, then we would advise that you explore the patient's spiritual lifestyle and work and social life, and then risk stratify them based on the idea of DAR recommendations, similar framework. So either into low, moderate risk, high risk, or very high risk. And if they fall into either of the very high risk or high risk categories, then we would suggest discussing with the patients the alternatives, such as winter fasting when the days are shorter. It could be better tolerated, for example, or we would ask them to consider maybe just fasting in the last 10 days, which are considered more holy. So a lot of patients would prefer to maybe fast during the last 10 days, or maybe just fasting non-consecutive days. So those are all options that are available for patients if they still wish to fast. And if they do still wish to fast, then we would encourage healthcare professionals to discuss optimization and emergency plans. And I'll come to that in the next few slides. But if you want to look it up, it's in the paper in detail. Now, talking about PD, as I said, there was only one paper, but this is based on expert consensus. And what we would suggest is that patients only fast for a 16 hours max. Although the study that I quoted, patients were actually dialyzing for 6 hours, but we feel that 6 hours is too little, and they may not be able to fulfill their dialysis requirement. So we suggest a 16 hours maximum time of fasting, and that they have at least an 8-hour period where they can actually dialyze safely. And although the patients in the study had icodextrin before, the daytime fill, but we feel that's not necessary. And if patients want to drain out, that would be absolutely fine. And they can have a daytime dry period, and the icodextrin may be drained out before they break their fast. So those are the different options for patients with PD. And another thing to suggest is if patients are on APD, I guess switching them to CAPD might make it easier. So perhaps temporarily they can switch from CCPD or APD to CAPD. So talking about optimization and education plans, so as I said, explore motivation, but ideally several months before, at least 4 to 6 weeks before, only because then it gives us time to make necessary changes to their medications, or if it's dialysis, where we might have to make changes to their dialysis regime, for example. So all of this ideally should be done several months before. And twice daily to once daily, if there are any medications, could be switched. So if they're on an ACE inhibitor or an ARB, maybe best to switch to alternatives if safe to do so, only because of the risk of hyperkalemia, or especially in CKD patients, developing a risk of further AKI. So we would suggest switching from ACE or ARBs to alternatives. And if they're on tolvaptan, especially as we know, the polycystic patients may be on tolvaptan, we would recommend temporarily stopping tolvaptan during the period of Ramadan or fasting period. So further optimization plans. So once we've done a review and changed any necessary medications, it would be ideal to recheck their renal function following any medication changes, just to make sure that they're actually tolerating it okay, and also put together a plan for monitoring during Ramadan and afterwards. So it could either be it could be weekly or fortnightly monitoring based on each individual circumstance. And if renal function deteriorates, so i.e. if they develop acute kidney injury on a background of CKD, then we would certainly advise them to stop fasting and to also repeat renal function to ensure it returns to baseline. And as we've mentioned during this talk, and also Salman's talk, trial fasts are certainly recommended, especially for some of the patients in the high-risk categories. It gives us an opportunity to assess whether the medication changes have worked, and also for the patients to actually learn for themselves whether they can actually tolerate fasting safely. So trial fasts certainly would be recommended as something to be discussed with them. We would advise a low potassium diet. So certainly, and also one other thing to mention is during iftar, which is the time when patients break their fast at sunset. In most cultures, dates or apricots are used for breaking the fast, only because it gives a burst of energy. And one of the effects of having dates and apricot is that it's very high in potassium content, and there's a very high risk of developing hyperkalemia. So if, say, CKD or dialysis patients were intending to fast, then we would recommend that they either choose a food type that are low in potassium or stick to just one date, for example, and to keep the potassium levels down. Fluid balance is extremely important, as you would agree. It's important that they keep well hydrated following iftar, but also not to overdo it. So we'll have to individualize the management plan. So for dialysis patients, might be a liter or liter and a half. So between the period of sunset to sunrise, where they start the fast. And also we would recommend that they actually monitor the weight, just so they know that they're not getting fluid overloaded. At the same time, restricting the potassium is important, but also meeting their nutritional requirements is important. And please do talk about sick day rules, meaning if they were to feel unwell, or if they have other additional comorbidities such as hypertension or diabetes, then giving them sick day rules and telling them when to terminate their fast if they either develop hypoglycemic episodes or feel unwell or dizzy or hypertensive, then or fluid overloaded and short of breath, then they are to terminate their fast. So dialysis, so the optimization plan could relate to mostly CKD patient, but if it's dialysis patients who wish to fast, then some things to consider are maybe shift changes. So if it's possible, if your dialysis unit has a evening or twilight shift, so maybe helping them dialyze after iftar. So after sunset, it could be around 6:37, or an evening shift, or some hospitals have overnight dialysis. So that could be an option for some patients. And also maybe asking them to fast on non-dialysis days would be safer than actually fasting on dialysis days. So fasting on non-dialysis days is probably recommended, although they would fall into the very high risk category, and we would recommend that they don't. But if they still choose to fast, then maybe advising them to fast on non-dialysis days would be better. And switching therapies from CAPD or APD would be better. And if they wanted to do APD, then 8 to 10 hours treatment at least with last icodextrin with the daytime dry. So all of those are different options. And please, if dialysis patients intend to fast, regular monitoring would be key and vital, especially to check their potassium levels and so forth. So what about transplantation and solid organ transplant patients? Can they fast safely? There's more literature compared to hemodialysis and peritoneal dialysis, more literature around transplant patients, mainly kidney transplants. There's a couple of studies about liver transplant, not really much about heart or lung transplants, only because worldwide the numbers are still small. However, kidney transplant, there are quite a lot of studies. So this was a meta-analysis that included 8 studies with about 550 patients. And it showed that within the same patient, when the GFR was measured before and after Ramadan, there really wasn't any big significant difference in GFR or serum creatinine. So there wasn't a change. However, if there was one study where there was a comparator group, so patients who were fasting compared to patients who were not fasting, transplant patients. But if you compare the fasting and the non-fasting group, there was a difference in their GFR, which was statistically significant. So the GFR change was between about 4.2 to plus minus 4.6 in those who did and who did not fast. But in the within the patients, there were really no difference in the blood pressures either. Systolic and diastolic blood pressures were similar. So similar to the CKJ paper that I showed you earlier, we published this in Clinical Medicine. And this is the risk categories for solid organ transplant recipients. Again, we've divided into 3, so low risk, high risk, and very high risk. And those in the high risk category, we would advise that they must not fast. And in this group, there are patients who have had a transplant in the last 12 months. For example, if patients come to me and ask me if they can get pregnant in the first 12 months, we say no. It's because there's so many changes that are happening in the first 12 months, immunosuppressive changes, the graft functions up and down, and there could be a risk of rejection. So we advise them not to get pregnant in the first 12 months. So similarly, we would advise the patients don't fast in the first 12 months. And if they're on twice daily formulation, we would recommend changing it to once daily. So if they're on twice daily tacrolimus, it could be changed to once daily tacrolimus. Or if they're on mycophenolate, we would advise that to be changed to azathioprine. So those are all options that are available, but ideally done at least 6-8 weeks before the start of Ramadan. Only then we can monitor their graft function, monitor their drug levels, and make sure we optimize them prior to the start of the fasting month. And similarly, if they're on twice daily oral hypoglycemics, then I would recommend that you actually look through the diabetes section, because this is covered in detail there, based on the different types of hypoglycemics, whether they can fast and they can't fast, and what sort of changes are recommended. And kidney transplant patients or any other solid organ transplant patients with unstable graft function. So if their function is deteriorating, or they're not well, if they've got cirrhosis or decompensated liver disease, or they're severely frail, then we would advise that they must not fast and they fall into the high risk category. However, if they are stable and if they're more than a month, more than a year after transplant, then yes, they should be able to fast with no ill consequences, provided we've gone through their medications and made the necessary changes beforehand. Similar to the CKD risk stratification, again, transplant patients I've just shown you this slide with the different risk categories: low, moderate, high, and very high risk. And if they still wish to fast, then on the left side of the slide, you can see all the different changes that we would recommend. Changing their immunosuppression, and also monitoring their tacrolimus or cyclosporin levels would be important prior to start of fasting. So this is just a summary slide of what I've just been discussing, what we've been discussing. So monitor graft function, make the medication switches ideally a number of months prior, talk to them about the fluid and nutritional requirements, and also the risk of rejection, and attention to immunosuppression dosing intervals. Moving on to the last bit of the talk, I've got 3 case studies to illustrate the points made so far. So the first one is a 57-year-old male patient attends primary care 1 month before Ramadan and requests advice on fasting, and I ask you what the suitability is of them undergoing fasting. So the background history is hypertension and type 2 diabetes. They're on amlodipine, indapamide, and metformin. The blood pressure in clinic was 127 over 80 millimeters mercury, but has been consistently below 130 over 80 over the past few months. The HbA1c has been stable over the last 6 months, and the patient has fasted last Ramadan with no issues. And also, when patients approach us, it's important to find out what their prior experience has been with fasting, if they had any issues with fasting, any illnesses, or if they tolerated fasting with no issues. So that it would be important to explore during the consultation what their prior experience has been with Ramadan. So how would we manage this patient? So again, we would suggest walking through the Ramadan compendium, the risk categories: very high risk, or moderate risk. And also please give consideration to the patient's age, frailty, previous experience of fasting, and if they have more than one comorbidity, maybe that the risk may be compounded. So as we know, CKD patients, they may have diabetes, hypertension, or ischemic heart disease, and the risk may be compounded. And it would be important to go through the different comorbidities and risk categorize each comorbidity separately, and then look at the combined risk for the given patient. For this particular patient, look at the cardiovascular and diabetes sections. And if we talk about the cardiovascular bit first, so if you can recollect, the patient had stable hypertension. The blood pressure is 127 over 80, and previous blood pressures have been quite stable. So because the patient has stable hypertension, they would fall into the low moderate risk, and hence they should be able to fast without any ill effects. If we looked at the diabetes section, again, the patient had stable diabetes and they were on metformin. So they should be, again, able to fast without any problems because they fall into the low risk category. However, if they had problems such as DKA or hyperglycemic episodes or acute illnesses or poorly controlled diabetes, then we would suggest that they must not fast and fall into the other high risk categories. So to summarize case study 1, optimal timing of medication, suitability of medication must be discussed. And if they are on a non-diuretic antihypertensive, example, a calcium channel blocker or an ACE or ARB, although we would suggest switching the ACE and ARBs, so they could be on a calcium channel blocker or doxazosin or hydralazine. So we would suggest that it be taken at suhoor or the pre-dawn meal. The reason for that is because, say, if they were to take it after iftar, and if their blood pressure were to go down, then during their prayer time and so forth, they might feel the ill effects of having taken the antihypertensive. So they might have partial hypertension or feel dizzy, and they may not be able to fulfill their religious obligations. Hence, it might be better to take it at the suhoor meal or the pre-dawn meal, and not take it after iftar. But if they are on a diuretic, the other way around, so maybe better to take it at iftar or after they break their fast, only because if they were to take it at when they start the fast at the suhoor time, then the diuretic effect can stop them from having any sleep by going to void and increasing the frequency of their micturition, and they end up staying up all night. Monitoring is important. Safety netting. Please do inform them when to break the fast, abstain from fasting if they develop any red flag symptoms, namely dehydration, dizziness, fainting, pre-syncope, or shaking or sweating. And please do document fully in patient notes for medical legal purposes. And also do suggest them and guide them, point them to discuss with their trusted religious authority in their own community to seek their advice on whether fasting would be recommended or not from a religious perspective. Case study 2, a 60-year-old lady comes to primary care 2 weeks prior to Ramadan and asks about suitability to fast. She presents with intermittent diarrhea and vomiting for 3 days, has a background of CKD stage 3 and hypertension, is on Ramipril, and despite the current symptoms, she still wishes to fast. And excuse me, bear in mind this is 2 weeks prior to Ramadan. So it could be that the symptoms may actually resolve completely, in which case if the symptoms resolve and we repeat blood tests and the kidney function is stable as prior baseline function, then she may be able to fast. However, if on blood testing there's evidence of AKI and the symptoms do not resolve, then we would advise that the patient not fast. And it's important that we actually fix them medically first, and that they are stable enough and well enough to undertake fasting, and that they're not undergoing or having an acute illness. And if they do have any form of acute illness, be it AKI, as in this example, or any other acute illness, and it could be COVID-19 or flu-like symptoms, then again, we do have a flowchart for that. So if they have non-COVID-19 symptoms, for example, or an illness which worsens through fasting, or that recovery could be delayed by fasting, then we would advise them not to fast in that circumstance. So in case study 2, which we've just been discussing, it's important to look through the CKD section and see whether the patient falls into the high risk or the very high risk or the low risk category. Because the patient has unstable kidney function, the patient would actually fall into the high risk category and should not fast in this circumstance. But if the patient still wishes to fast, then please do document and signpost them to appropriate monitoring, either in secondary or primary care. The last case study I have is of a 49-year-old male patient who attends primary care 1 month before Ramadan, requesting advice on fasting, background history of stable angina and hyperlipidemia, and quite a few drugs. We've got aspirin, isosorbide, statin, PPI, and GTN, which is sublingual, to be used PRN. So what should we advise as a healthcare professional, and how do we change the medications around? So this patient, because it's got stable angina, comes under moderate to low risk and would be suitable to fast. And in terms of the medication, the aspirin may be best to be taken after the iftar meal to avoid indigestion and gastric irritation. The nitrate could be switched to a long-acting one and to be taken after suhoor, at the pre-dawn meal. And the statin and lansoprazole could be taken either way at either iftar or suhoor. Shouldn't matter too much. What are the key learning points from here from the case study 3? Most importantly, if it's stable coronary artery disease, they should be okay to fast, although there are limited studies, but the expert consensus is that they should be able to fast. But if they've had acute myocardial infarction, or if they are post cardiac surgery for any reason, then the expert consensus and some of the guidelines advocate that they should not fast in the 6-week period. And the British Heart Foundation states patients may not be able to participate in cardiac rehabilitation while fasting, as they may be dehydrated or they may not be able to take their regular cardiac medications. So for those reasons, if they've had an acute MI or if they're recovering post cardiac surgery, then the first 6 weeks period, we would recommend that they do not fast. And sublingual GTN in itself does not necessarily terminate or invalidate the fast, and that's a reference in a BMJ paper, again from our group, if you wish to read. I'd like to thank colleagues from the BIMA team, authors, contributors, and reviewers, and also the BIMA Ramadan CPD team for putting together some of the slides and the case studies. Thank you very much, and happy to take any questions.
Thank you very much, Dr. Shafi. Very informative slides, and I hope that's been quite interesting for those that were listening in. Happy to open up to the floor if anybody would like to ask any questions to Dr. Shafi or Dr. Salman. Please just either put yourselves on, just take yourself off mute, or you can raise your hands, whatever is easier for yourself.
Assalamu alaikum.
Alexam.
Hi, so my son's just started dialysis in October. He's 16 years old. We're doing home hemodialysis. We have taken the choice that we won't be fasting because he's not had the greatest of start and he's still hovering with high blood pressure, and we do 5 hours of hemodialysis in the daytime, so it gives him time to go to college and things in between. So, but it was quite informative what you've just said. But he's decided himself, and we have spoken to some Islamic scholars, and they did say about giving money to charity and things, because he really hasn't been well. He's just about getting stable at the minute.
No, thank you. I mean, I empathize with the situation, and many of us want to fulfill the religious obligation, but also we've got an obligation not to make our underlying illnesses any worse. And as we were discussing, there are alternatives to fasting, which certainly we could look into, and your son could look into, or once they've had a transplant and they're better, it makes it all a lot easier.
Yeah, he is hopeful he's going to get transplant this year, because we're doing a living live donor, and we're just like encouraging him to do other things rather than just fast, because I know it's like a peer pressure as well. But he got diagnosed in May 2022 when he was fasting. He kept getting headaches and vomiting and things, and then just after Ramadan, his kidney function was only 30, so he's got IgA. So we don't know if that even triggered it. So we're quite skeptical about trying to let him fast. But he's agreed with it that he won't do it. But then last year, we were trying to keep his kidney function stable, and it was just hovering around 30, 28. So he didn't fast, but it was okay. School was supportive, his friends were supportive, but it was a lot of encouragement and making him understand that his kidney condition is serious and his friends are understanding. And living in a Muslim community, it's quite hard because people will just say, "Oh, will you be fasting this year?" and things like that. It's quite difficult to have those talks with people.
It's important to have a good support network, and looks like
Yes.
there's quite a good support network. So
Yeah,
that's quite
school
good.
have been really good because they said they will support it. It's just I think he gets questions now like, you know, Rehan, are you able to fast? Are you not fasting? And I think it's just trying to educate people.
Can I just pop in here? So obviously the work that we're involved in a lot with the organ donation work, and that was some of the questions that come up in one of the talks. And I remember one of the imams had said, when the Almighty has decreed for those that are unwell not to undertake fasting, but they can take other, you know, like you said, they can do, you know, giving food to charity or
Yeah.
supporting somebody and, you know, opening somebody's fast, even giving a box of dates to somebody that can help and support. Because what they say is, you are going above the laws of the Almighty to say that you know best, even though He has given concession to those that are unwell. So it's about, I know it's about teaching ourselves that mindset, because we do have this spiritual, as you say, a spiritual kind of guilt, because
Yeah.
it's embedded in us about and it should be obviously our children and how important Ramadan is. But like Dr. Shafi and Dr. Salman said, the importance is to keep well, and our bodies are an amana to us, so we have to look after ourselves. So if we know that this is fasting is going to trigger, you know, some people have very severe migraines and they know it's going to trigger, but then they know that how they can handle it within the first couple of days, and it's not. If you're making yourself really unwell and you're going to make yourself have more detrimental effect, I don't, you know, this is what I mean. We don't advise, because I'm not a medical consultant, nor am I a faith leader, but from the teachings that we've done and the work, I've been involved in this for about 8 years now, we know that we have to look after ourselves first. That's the first most. And I think Dr. Shafi can maybe agree with me on that as well, that we have to look at our health. But yes, people that are on dialysis or have had transplantation do consider fasting. But again, it's you know, if fasting is going to help for a short term, as you say, the fasts are getting shorter, so it might not be so bad. But like you said, if your son is on that stage, then you have to consider what's the benefits over what the spiritual kind of guilt, shall we say, sometimes.
Yeah.
But again, you know, everybody's an individual case, and faith leaders are always the best person to give you that advice. What do you think, Dr. Shafi? I don't know if there's anything in there that you'd like to add to.
No, I think all very valid points. I mean, yeah, completely valid. So absolutely. I mean, I think we've got that obligation to look after our health as well, and there are the alternatives to fasting. So I think we should be considering and looking at fidya and all the
Yeah,
other alternatives.
we came across, well, we do donate to charities, so we came across Abdullah Aid, and they actually have a project for dialysis patients, for refugees. So me and Rehan have decided that we're going to make a big thing about it and like get mosques involved and like try and raise some money for them. So that'll be like Rehan's contribution rather than fasting. So that's kind of encouraging him. He was actually on this Zoom, but he's come off. He's gone to watch Spider-Man.
How old is he, Apple, if you don't mind me asking?
It was Rehan.
No,
Rehan,
how
he
old
was
is
on,
your
yeah,
son? No, how old is your son? Is he
16.
okay? So he's at that stage, yeah, where yeah, I know.
He did come on for a bit. He has listened,
yeah.
but he's gone off now.
Great, thank you very much.
Is there any other questions? Just trying to see from any of the other speakers. If there are any other questions, obviously this will be recorded as well. So if there's any questions thereafter, if people are listening in onto the recorded, you can email into myself. I'm Bushra Riaz at kidneyresearchuk.org, and I can pass on any of the questions on to Dr. Shafi and Dr. Salman as well. So I think if we are, I think if that's how. If there aren't any more questions, I think we may close for the day.
Yeah,
Yep.
thank you very much for the invite and for organizing this. Thank you.
Yeah, I know. And thank you again, Dr. Shafi, and thank you, Dr. Salman, for joining today. Yeah, we'll, like I said, we'll be all recorded. If there's any questions, please do ask. Okay, thank you very much.
Thank you.